Welcome to this podcast on Introduction to Pediatric Cardiology. My name is Teresa Wu. Special thanks to Dr. Kim Myers, who provided significant input into all of the pediatric cardiology content. Before viewing this series of podcasts, it would be helpful to review some related materials that has been presented in the past. This includes embryology, neonatal cardiopulmonary physiology, newborn respiratory distress, and the information provided on cardiac murmurs by Dr. Rizkala. This series of podcasts on congenital heart disease will include the podcasts listed here. They are best viewed in order. At the end of this podcast on Introduction to Congenital Heart Disease, students will be able to understand the scope of pediatric cardiac disease, classify pediatric cardiac conditions, and name some common ways that pediatric patients present with cardiac disease. Let's start off by discussing the scope of pediatric cardiology. Pediatric patients can be born with cardiac disease, or they can develop heart disease over time. There are many ways to classify cardiac conditions, so keep in mind that this is just one way, and it is imperfect. Many people will categorize conditions differently. This is just a system for you to organize your learning as you start to dive into this complex group of conditions. In the category of congenital heart disease, you can think of the structural differences that patients are born with. First, there are cyanotic congenital heart diseases. These lesions tend to present shortly after birth with cyanosis and hypoxia that is not responsive to oxygen. Next, there are acyanotic congenital heart diseases, which include left-to-right shunts and obstructive lesions. There is a spectrum of clinical presentation for these lesions. The most severe left-to-right shunts tend to present with congestive heart failure. Patients with obstructive lesions tend to present with shock. Pediatric patients can have myocardial disease. There are many different causes, including genetic causes, and those acquired over time, just like in adult patients. Similarly, pediatric patients can have inherited arrhythmias or arrhythmias that develop in similar ways as adult patients do. And then there are acquired heart diseases involving coronary vessels and heart valves. Clinical presentation in these conditions is similar to what you have learned about in previous content, although the causes of these conditions in the pediatric population differs. In Block 2, we will spend the majority of the time discussing these conditions blocked in red, as they are quite unique to the pediatric population. The other cardiac conditions will be taught in other blocks. You might be wondering to yourself, just how common is this problem? Does a general physician really need to know about congenital heart disease? Well, the incidence of congenital heart disease is 1.22 per 1,000 live births. This works out to about 700 infants per year in Alberta alone. Half of these patients will require surgery and chronic care. Interestingly, the incidence of this is increasing. The vast majority of these patients survive into adulthood, so even those physicians who only see adults will likely encounter someone with congenital heart disease at some point in your career. So just how do patients with congenital heart disease present? With the advancement of ultrasonography, diagnoses are now often made by prenatal ultrasound, although this is sometimes still missed. Most critical cardiac lesions are detected within the first few days to weeks of life. Often, the diagnosis is made based on nonspecific symptoms such as respiratory distress, hypoxemia, or difficulty gaining weight. Sometimes, patients are asymptomatic from a cardiac perspective but are investigated for congenital heart disease due to other diagnoses that are known to be associated. While murmur is often associated, it is important to know that many critical congenital heart diseases do not present with a murmur. So remember that the absence of a cardiac murmur does not rule out a cardiac lesion. The subsequent podcasts in these series will aim to discuss these points in more detail. Out of the list of clinical presentations, the most common reason that a patient presents to a clinician with possible cardiac disease are murmurs, syncope, and chest pain. Interestingly, the majority of pediatric patients who present with these clinical presentations will in fact not have cardiac disease. So how do you know when to suspect cardiac disease if a pediatric patient comes to see you with these symptoms? As a reminder, murmurs and chest pain were already covered in Block 1. Syncope and presyncope will be covered in Block 3. Detailed discussion on approach to these 3 signs and symptoms will not be discussed in this podcast series, but for the sake of this introductory podcast, I will highlight a few key points. Let's start with murmurs. A cardiac murmur is extremely common in children. In fact, the majority of children will have an audible murmur at some point in their lives, especially when they are sick. The finding of a murmur just represents turbulent flow, and it does not necessarily mean that there is a pathological cardiac condition. The clinical history, careful physical examination to look for red flags are absolutely critical. When you go through a cardiac exam, there are associated findings that you should look for. It is all about practice. Here is an open access resource that you can access to train your ear in listening to various innocent and pathological heart sounds. As we go through the series on congenital heart diseases, we will also highlight some clinical findings that should make you more concerned if you hear a murmur. Now, what about syncope or presyncope? This will be discussed in more detail when we head into Block 3. Most patients with this symptom do not have a cardiac condition. However, cardiac disease should always be on your differential diagnosis. Here is a list of warning signs that should make you concerned for a possible cardiac cause and would warrant further workup and a referral to pediatrics or pediatric cardiology. Now, what about chest pain? Again, most pediatric patients who present with this symptom do not actually have a cardiac anomaly. The pain is more often related to respiratory or MSK pathology. However, cardiac causes is on the differential diagnosis and should be considered. Here is a list of presenting signs and symptoms that should make you more concerned for a possible cardiac cause for a pediatric patient presenting with chest pain. This was a very surface-level overview of pediatric cardiac illness. Be reassured that we will be going into more detail. In the subsequent podcasts in this series, we will dive into more detail on the most concerning clinical presentations as it relates to congenital cardiac diseases. Here are some key points from this introductory podcast. 1. Pediatric patients can have cardiac disease. This can be either congenital or they can be developing over time. Pediatric congenital heart disease is common, with an increasing incidence. This means that most general physicians will encounter a patient with congenital heart disease at some point in their career. 3. Patients with congenital heart disease can present with many different symptoms. Those with critical lesions will present earlier in life with hypoxia, cyanosis, respiratory distress, or poor growth. These symptoms will be discussed in this podcast series. And 4. The most common symptoms to present to the outpatient physician include murmurs, chest pain, and syncope. Most of these patients will not have a congenital heart disease, but it is important to identify the red flags and know when to refer. These clinical presentations are taught in other blocks. This concludes our introductory podcast. Thank you for listening.